-8 minutes to do this. So, and I could talk about this forever. So I'm going to try to be very, very brief if I could. So for this, I don't have any financial disclosure. The only disclosure I have is that I am a cornea surgeon. I do run a cornea service. I do transplant. So there are really only 3 messages that I want to get across in this vast topic of ours. And if you go away, remember this, that we should stop doing bad things to ocular surface endothelium, okay? And then steroid is your friend from a glaucoma point of view, not your enemy. Remember that. And then last but not least, post-keratoplastic glaucoma is a real challenge. I think Asma is going to give a talk about that later on in a different room, so we should just follow that. We know that we do bad things to ocular surface. Everybody knows about it, but we still do it. And then we get patients that refer to me like this all the time. They are on what they say maximum tolerable medical therapy, and their eyes are really red. And they tell the patient that you either live with a red eye or you go blind. Now that is not MTMT, this is OTTMT, right? This is over-the-top medical therapy. No one really should be on 3 medications unless you've had multiple surgeries. We should just get over and stop doing things like this. And if you stop them and you change it to a label preservative-free medication, this is what they look like 2 weeks later. Then it's much easier to manage. So let's just get rid of red eyes, get rid of multiple medications. We love to give our 5FU to our traps. We feel like we work really hard in clinic. We like to jab them and needle them until we get our trap down to a pressure of 10. And we totally ignore the fact that we really damage the epithelium. And this is what you will get to see 10 years down the line. The patient that you work really hard on the bleb, they get localized stem cell failure right at the top where you've worked hard on the trabeculectomy. And then they don't see very well. When you put some fluorescein on with the blue light, you will see this triangular shape, irregular epithelium. That's conjunctival epithelium that you've got that's grown down. And that's because of localized stem cell failure. And that's a real challenge. This patient will probably never see well again. And that's, you think it's a smooth looking cornea, but that's because of localized stem cell failure. So no, we don't want multiple 5FU. We want a good filtration surgery with decent mitomycin C and be done. Endothelium, obviously, everybody cares about, and glaucoma surgeons should really care about it. Take a picture of this. This is the percentage of endothelial cell loss that we cause in glaucoma surgery. Deep sclerectomy does very little. Mitomycin C is not bad. Trabeculectomy is not bad. As soon as you add mitomycin C, our percentage of cell loss increase. We all know tube surgery is bad for endothelium. We all know that. If FDA was to approve armored valve and bar valve, they would not approve it nowadays because the endothelial cell loss. And it's not just the tube that close proximity to the endothelium, but the change of the aqueous is hostile to endothelium. So no, think about the fact that we don't want to be doing multiple surgery on our patients. Traps, needling, revision, cyclodiol laser, then reluctantly put a tube in, and you wonder why the cornea goes and never comes back. The aqueous changes is significant, so you may want to just pick your best surgery and go with that, and that could be a primary tube. Don't think that because the cornea goes, I send it to my cornea colleague, that's okay. I'm the cornea colleague here myself, and I realize that my transplant don't last that well in the glaucoma patients. It's a significant higher risk of failure, so you do not want to be damaging the cornea endothelium. We'll come back to that, but steroid is your friend, not your enemy. So from a glaucoma surgeon point of view, there's no point telling your cornea colleague to back off the steroid. People who've got atopic eye disease, for example, is a classic. They live with steroid, they need steroid. If they don't have steroid, they develop shield ulcer, they would dramatically lose vision for the rest of their life. If your pressure is sitting at 30, they won't lose vision for quite a long time. So on balance, the cornea disease is much more important than the pressure. So they need the steroid, and we manage the pressure with steroid, not off steroid. Same for uveitic, same for cornea transplant. They need steroid. We manage the pressure on steroid. Don't give them a little bit of rubbish steroid, hoping the pressure will be okay. Last but not least, post-keratoplastic glaucoma is a real challenge. It's not really in any textbook. We don't know why it happens. We think we collapse the Schlemm's canal. We know that young patients with a long history of glaucoma or pre-existing glaucoma, when you do a transplant, especially a PK, the pressure problem is very likely to come. Big graft, long sutures, they are much more likely to get pressure problem. Nowadays, laminar surgery is better. We see less pressure problem with DALP, with DMEG and DSEC. Tonometry becomes a big issue when you've got a transplant, completely irregular. So eye care is not a bad device to use to check pressure. But also remember digital, i.e. these fingers are quite good in palpating. Pediatric people are very good at it. And that's what we need to have a little feel. Develop this feel with your fingers, what a pressure of 20 and 30 feels like. Assessing the optic disc and visual field is an unheard of test in a cornea clinic. Cyclodiode laser should never be done, as far as I'm concerned, in someone who's had a cornea transplant. It's such bad things to do. It's not your first port of call. Don't do it. Trabeculectomy don't seem to work very well, although it may not stop us from doing it just because it doesn't work that well. But again, you don't want to be giving multiple 5FU because of the toxicity. And also, remember that PK patients, 25% of them need to wear a contact lens. So creating a blend may not be contact lens compatible. So often you would go for tube. And for me, the tube of choice is the port tube, which I think is a better tube and more cornea endothelial friendly. Angle-based surgery is very hit and miss, so occasionally I may do it, but don't bank on it. I don't really favor a pars plana tube, just because of the fact that I don't trust my VR colleague to do a full vitrectomy, and I think they will damage my endothelium. But I would put it in the sulcus if I have to. DSEC, DMEG, I think nowadays their glaucoma is easier to manage. These patients are more elderly. I probably would be in favor more of a trabeculectomy or even something like a PRESERFLO rather than sticking a big tube in it. Pars plana tube is worth doing. Any possibility in a cornea patient, I would put it in a pars plana. Ultimately, teamwork is needed. Don't cut me out, I'm going to go 2 slides. If you've got an eye like this is severe chemical injury, it's still work in progress at the moment. Can I have that back? Still work in progress at the moment. You need a lot of planning. You're going to have to work with your cornea people, work with the oculoplastic people, the glaucoma side you'll be looking after. It's a massive teamwork without a doubt. And ultimately, from a glaucoma point of view, we're here for vision. We're not here for pressure. So think about the vision all the time. Stem cells and endothelium are really precious. Grafts in glaucoma don't last that well. So try not to get them to decompensate. And ultimately, have lunch and be friends with your cornea colleague. You're going to need them. Thank you.